Dr. Matthew O'Connor, who's a doctor of biochemistry. Matthew worked in the SINS Research Foundation, which is probably the first focused on the biology of aging non-profit research foundation in the world. And he's currently focused quite a lot on finding novel therapies to look at atherosclerosis, which is something many of us would like him to succeed in achieving. So without further ado, please, Matthew.
Cures. It's not a word that we like to use very much. It's a word that we're sort of afraid to use in aging and disease, especially in chronic disease. If you go to your doctor and you have a bacterial infection, they can give you antibiotics and you can be cured. But if you go to your doctor and they tell you you have atherosclerosis, plaque in your arteries, you're going to be talking about how are you going to manage it, how can you slow down its progression, maybe you should quit smoking. I want to try to imagine a world in which we stop thinking that way and start thinking about how can we cure the chronic diseases of aging. So, as Martin said, I'm a basic biology of aging researcher. I've been doing that for my whole career, worked on telomeres and muscle aging and mitochondrial aging. And now here I find myself running a cardiovascular disease company. So I have no training in cardiovascular disease, but I'm going to do something new. I've put together a completely new presentation for you, not just on what my company is working on the drug that we're developing, but what would it take to look at the basic molecular damage that accumulates with age in your vasculature and see how we could repair it and have that lead to improved outcomes and maybe reversal of cardiovascular disease. And my clicker's not working, so I either need a new one or I'm going to need someone in AV to run it for me. Okay, so the vasculature, it's what pumps blood through your whole body, right? You have arteries and veins, and they're basically the same thing. They transport blood, which transports nutrients, glucose, oxygen to all your organs, your brain, and then your heart is at the center of it. And so most heart attacks, when people talk about heart health, they're usually talking about vascular health. So you have problems with your vasculature, and that is what controls almost all heart attacks and a lot of other of the chronic causes of death. So this is a risk-adjusted chart of what kills people. So atherosclerosis, the plaque in your arteries, doesn't kill anybody. They don't write that on death certificates. But if you risk adjust heart attacks and strokes and COPD for our best understanding of what contributes to those diseases, you end up with something like 40% of all death being caused by atherosclerosis. Is that a first world problem or a third world problem or regional? No, it's everywhere. If you do a quick comparison of US and Mauritius, you see very similar rates of cardiovascular disease. So, and also between rich and poor. A huge percentage of rich people die from cardiovascular disease as well as poor people. So probably 40% of us are on track to die from something related to vascular disease. What we've been doing so far around this is all around management, risk management, and progression. So you have things that can regulate your blood pressure, you have a lot of different drugs that will lower your cholesterol, your LDL cholesterol, newer generations of those, next generation of Lp(a) drugs that are coming out, and now we have the weight loss drugs that help as well. But none of them reverse disease. They all slow it down. Accompanying vascular disease is inflammation, and there's been a lot of hope around anti-inflammatories because the inflammation in your arteries is very well correlated with having heart attacks and strokes. However, the clinical trials around the anti-inflammatories so far have been a bit underwhelming. And I think we may be getting stuck on cause versus effect. What I want to talk about is root causes, asking why 4 times and getting to the bottom of what are the basic mechanisms of aging that contribute to vascular aging and therefore vascular mortality. So I've created this list of 10 different types of damage, hallmarks, if you will, of vascular aging. And I'm going to try to run through all of these really quickly as kind of a roadmap for how I think we could construct a master plan of how to tackle vascular aging and vascular disease. I don't want you to get too caught up on these 10 categories and whether or not there should be 7 or 9 or 12. I'm more interested in the concept of there being underlying molecular damage that contributes to these different measurable and observable aspects of aging of the vascular system. So let's run through all of them really quick, and then I'd love to talk to all of you more about them individually or the whole concept later. So imagine there on the right side of the blood vessel wall. We've got to zoom in on the blood vessel wall, and the blood is flowing past the endothelium there. The endothelium is the first layer of defense. It's like your skin on the outside of your body. The endothelium is this layer of dividing cells on the inside lumen of your blood vessel wall. They, just like your skin cells, they turn over, they slough off, and they divide and replace themselves, and eventually they senesce. So you've heard a lot about cell senescence. You'll probably hear more about it here. Super important topic in many aspects of aging, and it's key to aging of that first surface of your vascular system. It helps regulate nitric oxide levels, and primarily it's a barrier of protection for your blood vessel wall. When they senesce, you get this SASP production, which creates local and systemic inflammation. And there's evidence in the literature that can contribute directly to rupture of plaques. So what can we do about it? Real quick, senolytics, I'm not doing a good job of summarizing them here, just put up a couple of examples. There's much better work about that from others. Potentially senomorphics could be effective. Maybe anti-inflammatories are a stopgap, but again, I think that going to root causes like senolytics are going to be a better approach there. You also have something regulating the nitric oxide system called the BH4, BH2 oxidation, where free radicals damage BH4, creating a shift to BH2. And so it's possible that antioxidants could help with that, but more likely that we need to find ways to reset the nitric oxide system. And fortunately, there are decent drugs for regulating nitric oxide. Okay, I'm going to speed right along now to a different topic, the second one, plaque. So this is one that I work on directly. How does plaque grow? So you start with a small lesion somewhere in one or more of your arteries, and it'll be like a little fatty streak. And even if it hasn't been diagnosed yet, probably everybody here, including me, has some of this going on in their body. Usually starts when you're a teenager. And you get little fatty streaks, and these immune cells called macrophages are supposed to come along and clean those up. And they're very good at that, just like macrophages are good at cleaning up all kinds of messes. And so they come, they invade the blood vessel wall, and they try to clean up those lesions. What happens slowly over time and with age is that they eat too much junk that they can't metabolize, and they just keep eating, and they turn into these blob cells called foam cells. And foam cells build plaque. There's a dogma in the field that foam cells are created by too much fat, by too much cholesterol, too much LDL cholesterol. But macrophages are actually cholesterol metabolizing machines. They're great at processing LDL cholesterol. What they're not good at is processing damaged cholesterol or oxidized cholesterol, the primary form of which is called 7-keto-cholesterol or 7-KC. And so what I think is happening is that when macrophages eat too much oxidized cholesterol, they stop being able to do effective metabolism. They form these lipid droplets, and they balloon up into these foam cells, and that's what builds plaque. So something that I was working on at the foundation many years ago was, is there a way, what would happen if we could selectively just get rid of that toxic oxidized form of cholesterol? Could we do something about foam cells? And after many years of research, we developed a drug, and I spun it out of the foundation and created Cyclarity Therapeutics. And we developed and tested this drug that very specifically removes oxidized cholesterol from cells, from macrophages here. And what we've shown for the first time is that we can turn a sick foam cell back into a healthy, functional macrophage. And we've just published this work, and we're very excited about it, and we've moved this into human clinical trials. So this is being tested in humans right now in Australia, and we are about a week away from finishing our safety testing in healthy volunteers. You don't need to be able to read all this. It's just to say that it's gone into 72 healthy people, and we haven't killed anybody yet. And so we've gotten permission to go into a small number of patients to test them for safety, as well as some preliminary exploratory endpoints. So we're going to look at inflammation markers. Even though our drug doesn't target anything directly to do with inflammation, we hope that because oxidized cholesterol is a driver of foam cell formation and a driver of inflammation, that we might see improvement in the inflammatory profile of the patients. And we're also giving them non-invasive CT angiograms before and after the treatment. And we'll see if we can regress plaque, change the characteristics of the plaque, and get improvement from there. And then, of course, we're hoping to go on to larger cohorts and develop that into a drug for atherosclerosis. Okay, back to stuff that I'm not working directly on. You've probably all heard of calcification of your blood vessels. The good thing about calcification in terms of studying it is that, like plaque, which only recently became pretty easy to measure. Now it's relatively easy to get a non-invasive angiogram, at least if you know where to look. Whole body imaging, I hope, will be coming along in the next 5-10 years. But right now it's still pretty localized. But you can get whole body calcium scores with a pretty low radiation CT scan. The bad news is that if your cardiologist comes back with a score that's anything other than 0, you're already progressing relatively far down the path of vascular disease. And there's nothing you can do about it to reverse it yet. There's no treatments that are approved to reverse it. The best you can hope for is to improve lifespan and treatments and try to slow it down. What I think we're going to need is some kind of targeted chelation therapies to remove calcium from the blood vessel walls. And indeed, there's some pretty crazy clinical trials out there where they actually injected people with EDTA, a common chelating agent, and it actually kind of worked. It's not necessarily good for other parts of your body, and so it's certainly not approved for that purpose. But it's been proposed, and there's a group working on targeting chelation therapy specifically to the blood vessel wall, which I think is promising. So I've mentioned inflammation. It's a popular topic for everyone. Whether or not it's a cause or effect of vascular disease is a little bit of an academic question. It's driven by many factors, including oxidized cholesterol, including free radicals, foam cells, senescent cells, damage to the smooth muscle cell layer. We can try to manage it with anti-inflammatories, but I think we're better off going to root causes, trying to get rid of the insults like oxidized cholesterol, cholesterol crystals, and senescent cells in and outside of the vasculature that are driving inflammation. So, what's the difference between an artery and a vein? It's kind of a trick question. It's really all just tubing. And in fact, they're interchangeable. You can get surgery where you can have a surgeon take a vein out of, say, your leg, and then stick it someplace else where you have a completely blocked artery, and the surgeon will cut out the broken part and graft in that vein, and now the vein is an artery. So they're the same thing. But how many times have you heard of somebody getting plaque buildup, atherosclerosis, in veins? It never happens. And the reason for that is I think, because of shear stress. It can't just be because of LDL cholesterol, because you have just as much cholesterol in the blood. It's the same blood in your veins as in your arteries, right? Arteries carry blood at high pressure out of your heart, and veins carry it at lower pressure more stably back into your heart. So you don't have this boom, boom, boom shear stress that is flowing through your veins, but you do in your arteries. What can we do about that? That's a tougher question, and I don't really have great answers for it. We can replace the damaged endothelial layer that we discussed before. If you have kinks and misshapes in your arteries, you can have them surgically corrected. Or maybe someday we'll all replace our hearts with continuous flow devices like one of the U.S.'s former vice president lived on for some time, and that'll take care of the problem. I'm not sure. This is a problem that needs a lot more study, and it's a big problem that is very underappreciated in therapeutics. So the best things you can do right now are exercising, maintaining good homeostasis with your nitric oxide levels, and then maybe work on maintaining your endothelial, hopefully with the upcoming senolytics that are being developed by many companies and academic groups. Pushing right along, we all know about blood clots and how you can get a big blood clot that can very suddenly and rapidly block a blood vessel, and then all of a sudden you're having a heart attack or a stroke. But what a lot of people don't know is that you get microclots, and they're often a significant part of the volume of a plaque. And so there is, I think this is an underappreciated problem that we need to start thinking about tackling. But I'm not sure that it'll actually be a huge problem if and when we start focusing on it. And so there's a target called fibrin that is a big part of the clots that there's been some work at looking at compounds that can break down fibrin that can then help clear out these microclots. And there's some people that come up to me often at conferences, and they show me these papers from some Asian countries where they've done these studies giving people high doses of nattokinase, which breaks down fibrin, and showing that it cures atherosclerosis. If it's working, what it's doing is dissolving part of these microclots. It looks like it could be promising, but it suffers from some of the same problems that you've heard about with, say, metformin and things like that, is that who's going to pay for proper clinical trials? All this stuff that's been published so far is completely uncontrolled, meaning there was no negative control group. You had groups of patients that were given high doses of this natural supplement and supposedly cured their atherosclerosis. Somehow, we need to find a way to do much better studies on this or new novel fibrinolytics and find ways to break down these microclots. So a different topic is fibrosis. So you've probably heard about fibrosis. It's the basic definition is the improper growth of collagen, extracellular matrix, and fibroblasts that are like scarring on different kinds of tissues. And so you get it in all kinds of organs. You get it in liver. You get it in the lung. You get it in muscle. And you get it in aging blood vessels, especially badly damaged ones where you have like a fibrotic cap on the surface of a plaque. I'm going to talk in a second about glucose cross-linking as a way to try to repair that collagen-based extracellular matrix. Fortunately, right now, there's a lot of excitement and a lot of work from companies like Insilico and others that are developing effective anti-fibrotics. And we've already talked about senolytics. And so I think a combination of repairing the extracellular matrix, dealing with senescent cells, and managing fibrosis, preferably not systemically, preferably localized to the insult, I think is the future of that. Smooth muscle cell layer is it's a kind of muscle different from your skeletal muscle that lines your entire vasculature, and it's responsible for maintaining the integrity, and it contracts and relaxes in response to changes in pressure, and it's a key modulator of the health of your blood vessel wall. So here on the left is what a healthy, well-organized, smooth muscle cell layer looks like, and on the right is where you have, it's kind of an ugly drawing, I apologize for that. On the right, you have disorder of the cells that are not lining up anymore so that they can do their contraction or relaxation properly. You have cell death and necrosis. You have calcification that's happening there. And you have this very weird process that happens where aging smooth muscle cells start to turn into bone-like cells, which is really, really bizarre. And so you have all these bad things that are happening. So what can we do about that? Well, hopefully some of the other things that we've already talked about, senolytics. It may be that cell replacement therapies, it's going to be really hard to target cell replacement to the vast number of kilometers of vasculature that you have in your body. But perhaps some kind of advanced cell replacement therapy can help. Perhaps in vivo reprogramming could help, especially if it could be targeted specifically to the blood vessel wall. and then, of course, the decalcification. But it's another tricky problem. The nice thing about the osteogenesis is that we've been working, and there's a lot of drugs that regulate the turning on and turning off of the osteogenic program for osteoporosis. So I wonder if there's a way that we can target some of those drugs to the vasculature in a way that we're not going to accidentally cause osteoporosis. Okay, let me speed through my last couple of topics here. One of my favorites being blood vessel stiffening that is really underappreciated. So your blood vessels are made to be very soft and supple and flexible. And we've already talked about calcification and plaque buildup, both of which contribute to stiffening. Another thing that contributes to stiffening is glucose cross-linking. So you all are suffering from the long-term effects of type 2 diabetes. And that's from glucose. And glucose reacts with proteins non-enzymatically, very slowly, with a reaction called the Maillard reaction. And it causes things called AGEs, or advanced glycation end products. And one of the biggest things that those do is since you have all the blood in your blood vessel wall carrying all the sugar around your body, is react with the proteins in your blood vessel wall. There was a company that I think was way ahead of its time some 20 years ago that developed a drug that was supposed to reverse this. It actually got pretty far in clinical trials. They were targeting it for blood pressure lowering, which it actually did. Most people don't know this. It did lower blood pressure, but not as dramatically as the ones that work more directly just on regulating blood pressure. And it was very safe. So I think that this topic of developing small molecule drugs to target glucose crosslinks is an idea that needs to be revisited. There is a newer company called Revel Therapeutics, run by a friend of mine, that's developing enzymes to target glucose crosslinks. Another aspect of flexibility that I didn't mention is elastin, which is a protein that does what it sounds like. It's supposed to confer elasticity to the extracellular matrix, and you lose it with age. It doesn't get effectively replaced, but there is evidence that external replacement of elastin to tissues reconfers flexibility to those tissues. And there's a company called Elastrin that is working on that right now. So last topic is vascular leakage. And so like it sounds, you can get bleeds from the brittleness and the breakage of your blood vessel walls. This loss of integrity leads to invasion of stuff from your blood into your blood vessel wall that shouldn't be there, immune cells, proteins, things that don't belong there. I think the two biggest problems there are what we talked about already, the endothelial, three problems. The endothelial cell wall, the glycocalyx, which is on the surface of, it's this sugar protein surface of the endothelial cell barrier, and then the tight junctions between those cells. And there's a company run by some friends of mine at Reservoir Neuro that think they have cracked the code on regulating the tight junctions, and they're developing a drug to try to fix that. So I'll stop here and make the claim, make the pitch that we should take a divide and conquer approach to comprehensively try to repair the vascular system. And we're going to need all kinds of new diagnostics, some of which have already been developed, but we need new diagnostics that are being used clinically to measure surrogate endpoints. And maybe someday we'll be able to be looking at taking pictures of plaque and turning them back into healthy young arteries. Thank you.
Thank you, Matthew. Thank you. So we've kept you a little bit from your lunch so that you can keep your arteries nice and clean without all the damaged foods. We may take one lightning quick question, and then I'll talk about time for lunch. So what practical, clinical, and lifestyle steps can be implemented today in Mauritius to slow or reverse cardiovascular disease at the population level? I know that's a big question, but if we can get a very short answer, please.
You know, I'm really focused on the future and on repair of the vascular system. So, you know, prevention isn't something that I focus on. You know, diet, exercise, taking lipid-lowering medications. I'll say one thing, a little bit controversial, and I'm not an MD, so this is not me prescribing things, but the outcome measures for the PCSK9 inhibitors are looking so much better than the statins. And the cardiologists at the conference all know this, but the regulations are still very conservative, and everybody's still being prescribed statins first. I would skip straight to the PCSK9 inhibitors. That's my non-official non-professional advice on that.
Okay. Matthew, thank you very much.